As we get into our first presentation now with Liz, this is a good time to get out a pen or put your fingers on a keyboard or however you like to keep track of some of the information. We'll share all of the slides afterwards, and I'll be watching the chat for any questions. I said we're really lucky to have Liz. She's a great family doc. She's based in Ottawa. She works with Ontario Health as their senior clinician advisor. She's also a professor with the Department of Family and Community Medicine. She is a bilingual physician, and she's somebody who's worked in different jurisdictions. So she knows so much of the issues we're going to be exploring from many different sides. Liz, I'm going to pass the virtual mic to you, and you're just going to let me know when you want me to flip the slides forward.
Sounds great. Thank you, Peter. I just want to make sure you can hear me okay and see me okay. Technically, we're good. Okay, great. Thank you for that introduction. And really, it's a privilege to be here with you. This is such important work that you're embarking on. And as Peter said, I'm a family doctor, so I've been practicing for 20 years. Maybe that's the hat I wear most warmly and tightly on my head. But I have other work that I'm doing right now. So I am now part of Ontario Health. I'm the senior clinical advisor for primary care. And I'd note that this is a new job. So this is a position that actually has only been around for 3 months, and I am the first person to hold this job. And I think it's a signal about the importance that Ontario Health is placing on getting it right in primary care. And, I think we can acknowledge we're not, healthcare is always evolving. It's always a journey, but I think we can say we don't quite have it right yet. For sure, if we want to do it right, having the perspective of patients and caregivers and families who are the ones for whom all of this is about. I think everybody wants to do the right thing in healthcare, whether you're an administrator or a nurse or a doctor within the system, but we need to hear from all of you. So this is really important. And I can tell you personally, in terms of the work that I do in Ontario Health, I'm really looking forward to hearing what you will have to say in February. So thanks again for having me. Just a note to say I don't have any conflicts of interest and would disclose that I do have salary support for the work that I'm doing at Ontario Health. So next slide. So these are some of the questions that Peter and Tara asked me to cover. A really brief introduction into, what is it to be healthy in Ontario and in Canada, and what are some of the factors that are at play when we talk about people's health and what the healthcare system has to deliver on. What is primary care? How is that different from primary health care, from specialist care, from hospitalist care? So I'm going to talk about that and why it really matters. And then just some reflections, and some of that will be personal, honestly, just me as a family doctor, not me in my government role, about the crisis and what it's like to be a clinician working within the healthcare system right now in primary care. All right, so here we go. How healthy are Ontarians? So this is our population. I think it's important to kind of start from that and say we are somewhere between 14 and 15 million. This is the 2021 numbers, or closer to 14 million, located all across the province. But you can see a huge proportion that are there around that big blue part of the donut on the top is in the Toronto area. And I'm calling in from the east area over here in Ottawa. And then a smaller proportion up there in the north, but that's important because healthcare delivery really varies geographically, and so what we do in the north may not look the same, will not look the same as what we do in the Toronto area. And then again, just a little snapshot there of we have a rich variety in terms of people who live in Ontario, some of whom are immigrants and some of whom are not. So just a little snapshot of some of that variability that we're seeing. This is really critical when we talk about healthcare. So these are 3 different graphs that take a look at male and female populations on either side there. One from up to 1992, and then 2021, and then looking to the future. And basically what this is showing you is like as you go up, that's older. So it's like a vertical line upwards, and then the bars go out to tell you, how big is the proportion of population that depending on what age you are. So bottom line, we're getting older overall as a population, and that obviously has an impact. Doesn't mean that when you get old, you're not going to be healthy. So there are lots of ways to age healthy for sure, but generally as you get older, you're going to accumulate more illnesses. And we know that at the very end of life, those are some of the most burdensome years in terms of what the health issues you're going to be facing and your experiences and interactions with the healthcare system, including primary care. Next slide. So these are really important in primary care, and I'm sure really important to all of you. And these are what we call sort of the upstream factors that play a role on our healthcare, and they're critical. So looking at things like smoking and alcohol, also sedentary behavior, and then the foods that we eat, right? So all of these behaviors are things that play an enormous role in our health, and tend to be things that probably we don't spend enough time talking about and encouraging. And there's a lot of investment in what I would call the downstream parts of healthcare, where we're dealing with the impacts of some of these behaviors. Next slide. These are just two snapshots of some factors that I wanted to highlight that impact health status. So you can see on the map there of Canada, and as with the color, that's the blue color there, you can see, depending on where you live, your life expectancy can vary a lot, right? So a range from, almost 10-year difference in terms of life expectancy, depending on what part of the country you live in. And then on the bottom there is looking at gender, and then also looking at income. And I think this is, health behaviors are one piece that drive how what people's outcomes are, but absolutely these other determinants like our income and geography also play a really important role, and have to be part of whatever kind of program of healthcare and preventative care and public health that we're putting forward to Ontarians. Next slide. So what are the illnesses that are leading to death in Ontario? Well, leading cause of death by far are chronic diseases. So a chronic disease would be something, we've listed them. So the sort of the big pie on the left, and then the little pie is all of the different types of chronic diseases. So those range from cardiovascular disease, so that would be heart attacks and strokes, cancers, we know what those are, and then diabetes, obviously, and then respiratory illnesses, those would be things like chronic bronchitis or emphysema. And you can really see that focusing on a health system that can really look after people who are living with illnesses that are chronic. In other words, it's not just a one event like a broken leg, it's something that is ongoing. Having a system that can respond to that reality for patients is really important. Next slide. And I just thought I would put this up too. So this is obviously something that's been on everybody's mind. So, how are we doing in terms of outcomes around COVID-19? And so this is a graph that, I guess I stretched it a little bit funny, sorry. So, but I think you can still read it. So this is looking at deaths across different countries. And the graph is giving that to you, deaths per million. So you can see that Japan is way down there in terms of the lowest number of deaths, and Canada had comparatively actually very few deaths as well. So we did a lot of things right in terms of high rates of vaccination and preventative health measures. And so this is, just another piece of something that I think is on all our minds in terms of what the healthcare system has been dealing with, and we'll talk a little bit more about COVID-19 and the impact that's had on patients and also on the health system. I thought I would add that as well. So that's a bit of a snapshot of health. It's by no means the full scope, but I just thought I would give you a few of those highlights and think a little bit about, knowing that, what does that mean about what our healthcare system and our primary care system specifically have to deliver on. So what is primary care? Great question. So I actually pulled this slide from, it's a picture that comes from the UK, actually, from the National Health Service, but I really liked it because it looks at the four quadrants of healthcare and gives you some examples, and I think illustrates how they're different. So in the very bottom left there, you have community health. And this is a really important part of healthcare that's delivered. And that's things like our sexual health centers, child health services. So these would be services in the community. And I would put public health in there as well. Then if you move up to the top left, you have primary care. And we often talk a lot about, what's these terms of primary care and primary health care. And they're not interchangeable. I would say primary health care is a broader term that would describe to me all of the things in this quadrant. So they've labeled this as primary care to include dental care and eye care and community pharmacies, and then also general practice. So I would call all of that primary health care. And for me, the primary care is what we would sort of typically say the medical care that's happening in the family practice. But that's your first point of contact. It's the beginning. That's why we call it primary of your experiences with the healthcare system. And then we have what's called secondary care. So secondary care would be specialist care. It would be care in your emergency department. It might be, mental health care that you're receiving, and is care that would be delivered often in a hospital setting. And then finally, you have tertiary care. So this would be specialized. Think about that as like specialized hospital care. So a tertiary care center would be one of these special hospitals that might provide something like neurosurgery or transplants or very special care for children. So that would be the tertiary care. So you can probably, and then those are the patients in the middle, and you experiencing all of these different types of care. Next slide. So in primary care, and I said I've had 20 years practicing, and I've also had 20 years teaching as well. So new medical students and new residents who are learning to be family doctors. And this is something that we talk a lot about in primary care when we're teaching what it is to be a family doctor or what it would be to be a nurse practitioner working in primary care. So we talk about the 4 C's. And I think these are important just sitting on for a moment, because they are really the values, I guess, and the principles of the work that we do. And it's kind of a catchy phrase. And I will say, I know there are 5 bullet points there. So there's 4 C's, but we often add another one down at the bottom. So, loosely it's 4, but there's really 5 concepts that I think are important. So the first is first contact. So that's the idea of access with the health system. So primary care is the first place where you go to receive your health care. And then from there, the decision is made, do you need to be referred on to secondary or tertiary care? Or sometimes do we need to support you to be referred into community care? The care in primary care is comprehensive. So it's not about just looking after your sprained ankle or looking after your high blood pressure or looking after you at a certain age. It's about all of that. So we really focus on that concept of looking after people. We sometimes talk about looking after people from cradle to grave. So that's a critical part of primary care, and it's part of why primary care works so well, is because it does everything. The next would be continuity. So this is the concept that you get to see the same person or the same primary care team again and again and again over time. So we are the holders of the story over time for a patient. And that's very different from, say, when you go to a walk-in clinic, and that can be important if you have a one-off critical issue, whatever that might be. But especially when we start to talk about things like the chronic diseases that I mentioned at the front end, having somebody who knows your story is really important in terms of delivering on care that we know is associated with good outcomes for patient health. The next C is coordination. And so obviously all parts of the little square that I showed you should be working well together and connecting with each other. So I can say we probably have ways to go for sure in terms of doing that, but that is a critical part of what we try to do in primary care, is continue to be coordinated. And then finally, and there is a C there, I guess, if you look at patient-centered, but it is this concept that primary care is highly relational. So it is about being focused on what the patient needs and what their family needs, and building up that relationship over time so you really understand what's important to that person. And then they can, bring that becomes a part of the care that we provide, is really through building that trusted relationship. And it's my very favorite part about being a family doctor is about that relation that I have with my patients. Next slide. So this is a little academic-y, but I have to tell you, this is my hero in family medicine, and actually Tara organized for this person who built this sort of structure for what are the building blocks of primary care. His name is Tom Bodenheimer. She invited him recently to come to Toronto, and I was able to be there and meet him, which was wonderful. He's an American who comes from California. And he developed this concept of building blocks for high-performing primary care. And I think this really recognizes, I'm not going to go through all of these. There are 10 of them, and they build on each other. But I think the concept here, to me, to take away from this is, it's complicated if we want to get this right. It's not just about, putting up your shingle and having a black bag with your tools in it and opening up your door. That's part of it, but there's a whole lot that has to be included around the actual providers to make sure that really we have high performing primary care, not just low performing primary care. So these will probably be some concepts that come back as you are considering what's important to you as a patient in your own experience of the system. Next slide. So why is primary care important? This is, really a critical piece to understand. I feel that sometimes there's just there's maybe an over focus on acute care, and I think we can understand why that happens when somebody is really, really sick. It's really important that we make sure that they get that urgent surgery or cancer treatment immediately. I think that there is no question that the acute care sector is critical. But what we know time and time again, when we look within our own country, within our own province, and anywhere else in the world, is that you will not have a high performing healthcare system if you don't get primary care right. And one of the reasons for that is that interactions with the primary healthcare system really form the kind of are the most important and the most common interactions that happen in any given day. So just by sheer number of visits and encounters, you really better get this right. So this is a picture of what's happening in Ontario on any given day. And you can see there's, the big block on the outside is how many visits there are to family doctors. And, there would be more if we added in the visits that happen to nurse practitioners and the visits that may be happening with other primary care team members, if you happen to be an Ontarian who works or who gets care in a primary care team. But unfortunately, due to data limitations, honestly, we don't even have data on some of the parts of where those encounters happen in Ontario in the primary care system. But you can see it makes up about 50% of all healthcare visits in the province in any given day. And then I put that arrow in there because the other thing that happens is that if you want to get into any other part of the healthcare system, whether that's a CAT scan or in to see a specialist or to be referred to a surgeon, all of those transitions of care happen through the primary healthcare system. So this is, one reason why it's really important to get this right. Next slide. And this is another reason, which is just part of the picture around the evidence for the benefit of a very strong primary healthcare system. So this is one piece. I talked about those 4 C's, and one of them is continuity of care. So these are slides that come from Alberta, where they did a review of all the research that has been done, looking at how does continuity of care, so that concept of having the same primary care provider over time looking after you, how does that impact on the outcomes of care? And the numbers there, 8 out of 10, for example, under preventative care, or 61 out of 64 for utilization, those reference the studies. So there would have been 64 studies looking at how does the continuity of care in primary care impact your use of the healthcare system? Does it help prevent unnecessary emergency department visits and hospitalizations? And 61 of 64 research studies showed that it did. And if you look at the one down on the bottom, satisfaction, so that obviously is critical. That's patient satisfaction, so that's 15 out of 16 studies showed a strong relationship. So this is Canadian data. This is critical data to understand. So you have both, like, just primary care is important because of how much it makes up of all of what happens in the healthcare system. And it's also important because it really drives cost, quality, use, and experience of the healthcare system. So next slide. All right, so this is a little summary I'm going to give you of Ontario and primary care, and I'm happy to take more questions. So I'll try to, I can get really sort of, excited and in the weeds about this, and I know it's going to be important for you to follow up with me if I've not gone deep enough, and I'll try. So I'll try to hit the right balance here, but maybe expressing that, of course, I have some enthusiasm for this part of it, because this is where my work lies, is in terms of actually what are we doing in Ontario and are we getting it right? And this is the work that I would hope that this panel could help us ensure we're doing properly. So two sort of big buckets that I think are important to understand when we think about primary care in Ontario. So one is there are different ways that we are paid as primary care providers. And when I talk about primary care providers, I'm chiefly talking about the two main ones would be family doctors. They're about who make up the majority of primary care providers, and then nurse practitioners. So those are generally what I'm talking about. These are the ways that we're paid. These are contracts that we sign with the ministry. And the third bullet point in the top has the three big categories for how we're paid. So fee for service, the concept there is that for every time that I deliver a service, if I was paid fee for service, so every time a patient comes in to see me, I bill the government and I get an amount of money. That's fee for service. And that used to be the main way that people were paid in Ontario. In terms of, and at that time, it was really mostly physicians. So you paid, for every single service. The second way is capitation. So this is the way we're moving now, is towards what's called capitation. The idea of capitation is that as a healthcare provider, depending on the age and the sex of a patient that I look after, I would get a lump sum to care for that person during the year. And so that would mean whether that person came in not at all or 10 times, whether they had 2 problems or 10 problems, I would get an amount per year. And then the final way would be a salary. So that would be different. Not that many are paid by salary. So I think most of you would know what that would be. So that, just would be a lump sum, whether you had, 10 patients or 100 patients or 1,000 patients, you would get a salary. And I put blended in there because sometimes what happens right now is that we get a little bit of both. So most commonly right now, we're paid with a combination of fee for service and capitation. So that's one thing, is how the healthcare providers are actually paid. The other is the practice model. So that's kind of the structure in which the care is provided. And so some doctors work solo. Again, that used to be more typical. Now it's much, much less typical, but that concept of having one doctor with, their black bag and the little office, that's one way. Much more likely now that doctors and nurse practitioners are working in groups. The other part of the practice model that I would say is important to highlight is whether or not you're working in a model that is team-based. And when we talk about team-based, the idea there is that it's not just a doctor and a nurse practitioner. There's other healthcare professionals who work together. So that could be look differently depending on what kind of team you're in. So it could be nurses, could be pharmacists, could be mental health specialists, so dietitians. And the main team models right now in Ontario are something called the Family Health Team, community health centers, and Aboriginal Health Access Centers. And then finally, there's a new model of care, which are nurse practitioner-led centers. So these are models where nurse practitioners work independently in a group to provide primary care. So those are kind of two distinct concepts. Next slide. So I call this the alphabet soup. This is not for anyone to memorize all of these, but just for you to know that we have all of these different names for the different kinds of models and ways that people are practicing in primary care. You might recognize the one that you're in there if you are somebody who has a primary care provider, and you can see on the left, I talk about kind of how you're paid. Is it by salary? Is it by capitation? One of the interesting things about Ontario when we think about primary care reform is actually Ontario really has led the way in the country in terms of looking at payment reform, which is only one part of primary care reform. But this alphabet soup reflects that over the last number of decades, we've spent a lot of time trying to understand what is the best way to pay primary care providers. And I think we've learned some things along the way. So, but I won't spend much more time in here. So next slide. So this is what I was mentioning. So this is sort of where we were in 2002, and you see that big green part that says 98%. So those were doctors who were working either solo or in small groups, but using that fee-for-service model. And now look at where we are now. So it's kind of a whole sort of rainbow of options in there. And the majority are in that blue group. And that blue group are doctors who are paid by capitation. That's called the faux model. And they are paid by capitation mostly with a little bit of fee for service. So these would be doctors working in groups, not necessarily in a team. And they would be getting that lump sum depending on how many patients they look after and the age and sex of those patients. Next slide. All right, this is a vision. It's a national vision, but actually, really, we've seen something like this in other jurisdictions. This concept, we see it in the States, for example, as well, and in Europe. It's called the patient medical home. And the idea here, kind of following in on that whole alphabet soup and sort of some of the what the different ways that care is provided. This is a vision that can apply to any of those practice models if we if we chose to go this way. It's an evidence-based idea for what primary care could look like. And you can see it includes things, if you look in that middle section, that's the light blue, it includes things that I think most people would really want, right? Patient-centered care, care that's accessible, care that's provided by a team, care that's community adaptive. That means that actually, you're not just looking at, your own four walls, but you actually look out into the community and consider what is the role of this practice in terms of ensuring the health of the community. And, I mentioned the family health team. So this is one place where, I think this model, this North Star idea is being realized. Community health centers would be another. In some areas, we are also seeing something called primary care hubs. So this is a new concept where we're trying to pull together in a community, a team that could be accessible to solo doctors or small offices around, so they could access some of those team-based services in what we're calling a hub model. Only 30% of patients in Ontario receive team-based care right now in a structure that would look something like this patient medical home. So this is not okay. And this is something that's really a focus in terms of where we need to go as a province. So next slide. So this is very busy, but I think it's actually kind of a neat slide to have. And I don't want to, I'm not going to go through all of these. This is actually the primary care reform in Ontario. So where have we been? It goes all the way back to 1960, but Peter talked about what was happening even before then, and then just up to 2010. And I've highlighted a couple of key places where there has been reform. So you can see over there in the 1970s, that's when the community health centers started to emerge. They're actually a very old model. And if you go further to the right there, what you can see is there was a big infusion that came from the federal government in 2003 that was really focused on trying to accelerate primary care. And every province decided to do it a little differently. But what happened in Ontario, as I said, if you bump up to where it says 2004 and the introduction of the family health teams in Ontario, we invested in some modernization around the payment model, so moving to this capitation model, and also in the introduction of these family health teams. So I don't know what's going to happen after this, but I think these are the kind of conversations that need to help inform the next phase of transformation. Next slide. All right, and these are the Ontario health teams that Peter mentioned. So these are a relatively new structure, but the vision and the concepts behind it are not new. So the idea is up there at the top that as a patient right now, the experience is really you go, one way to see your primary care doctor, and then you might go somewhere else to talk to somebody in the hospital, and then over somewhere else to get home care. And those things do not feel integrated. We know they should be integrated. We know it should be a seamless experience for the patient. So that's the idea of an Ontario health team. These are local. So there may be several of them in one city if the city is big enough, or maybe only one if you live in a smaller town, and everything is pulled together. So all those structures are connected and have shared objectives and planning around healthcare priorities and healthcare delivery. And the next slide just has a bit of a map. So you can take a look there. This does not have like the actual name of the Ontario Health Team. These are numbers. But if you went to this website, they actually link to, they all have actual names. They're not just, 1014, but you can kind of see there maybe where you live and, what sort of the size of the population that the Ontario Health Team in your region is looking after, for example. All right, next slide. I'm just about done. I think the last piece is, do we have a crisis and what's going on? So I would say, yes, we are definitely in a time of enormous strain for the healthcare system. And these are just a couple of comments that have come, or headlines that have come through the media, but I'm sure you have read these. You may be experiencing this as a patient. So a couple of things that I would just say. So one is that COVID has been incredibly demanding on even the highest performing healthcare system. It doesn't matter where you are in the world, or certainly where you are in Canada. COVID has been an incredible strain. And, obviously looking after patients who have COVID, but also what we're dealing with now is all of the backlog of COVID. So all of the things that were not done over the time of the pandemic, because surgeries weren't operating the way they were before, because patients weren't able to be seen in person, when there were times that we had to, shift towards virtual care. So, and I think this is going to go on for several years, to be honest. It's going to take us a long time to get back to where we should be. And in primary care, we're working hard to try to take a look at pulling these pieces together, whether it's pap tests or vaccinations or, visits for people with diabetes. So this has caused a huge strain in our offices in terms of the demand for care. And a whole other piece in here would be the rise in mental health care. And we've seen a 25 to 30% rise in terms of the mental health care needs over the pandemic. But there was a lot that was a challenge even before that. And, I think that one of the things we have to recognize is that healthcare is more complicated, first of all, because patients are older. And that means there are more care needs. Medicine is also way more complex. My father was a family doctor, and he early on told me in his career when he was practicing in Nova Scotia that he was able to look after his patients, and then people would call him to also help with their animals. Like, you went and took teeth out of horses and et cetera. And there's just no way you could operate like that right now. The number of medicines, the number of illnesses, the kinds of treatments, of diagnostic imaging that are required right now to keep up with the standard of care is just absolutely not where it was decades ago. And that makes the delivery of healthcare very complicated. The other piece that I would just say is the strain in terms of human health resources. So this 1 in 5 Ontarians could be without a family doctor. Some of these data actually are data that Tara has worked really hard to understand in Ontario. And this is a worrisome reality that despite what we know about primary care, actually we're looking at fewer people picking primary care, so our family medicine as their career choice. We're looking at people retiring early. And so it's a hard time right now, I'll be honest with you, in the healthcare system. And no matter where you are, but I can speak obviously to the experience in family medicine and in primary care. It's a difficult, challenging time. You're somewhat buttressed if you work in a team, and I'm lucky to have that opportunity. But I think this is part of the conversation I think we have to have is just about sustainability in the system, and figuring out ways to retain the nurses and the doctors that we have and not lose more. So I'll stop there, and happy to take questions. I can see there was lots in the chat.